I'm very grateful to be here today. I've got a lot of paper here, which I think some of which is yours, which is about how long I've got. So I've got about 15 minutes, and so look, thank you for inviting me here today to speak. Thank you for Sean and others who have facilitated my attendance here. So thank you. And mine's not going to be so much about drug policy, it's going to be more about the practical aspects of policing. So, in terms of policing, I just want to sort of indulge a little bit in my family history. So you might want to look at that police officer there. That's my grandfather, who is a London bobby. And he would get up each morning, get into his uniform, have his baton, his whistle and his helmet, and he'd go around policing his community. And every now and then he would ring in on his police telephone, the TARDIS, and report in. And he knew his community, he knew the people that he worked for, and he rarely went to the police station. He might go every now and then for a briefing, but he'd ring in and say, look, I'm on point. But he knew the people who he was working with. He knew the people who lived in his community. He knew their problems, he knew their issues, and that was real community policing. That was the essence of policing as I knew it, as my mother would talk about her father in a tough time, you know, during the Depression in London in the 30s. So, and his, I guess, if you look at those Peel's principles, his approach to policing was very much about, the police of the community and the community of the police. And the absence of crime was how police were judged. So if you look, though, at the trends of militarisation of the workforce, we see that there's results driven by statistics and arrests. So this is more law enforcement. Reactive response driven, large complexes, increased mobility, less engagement, isolation from community, promotion and service recognition defined by arrest numbers, strongly aligned to government control, and agents of social control. So that's law enforcement. Whereas in policing, and we see some of the responses or the results of that, in policing's more about perceptions of safety, a key measure of success. So rather than just numbers, it's about perceptions of safety, proactive and preventative focus, community policing philosophy, meaningful engagement in using a partnership approach, decentralisation of authority, local autonomy, promotion and service recognition is defined by a use of problem-solving approaches, not driven by a political agenda. Greater openness and transparency of governance systems, gatekeepers, to a range of systems, including health and welfare. So mental health crisis intervention, violence, including family violence, gender-based violence, homelessness, road trauma, emergency and disaster management. So these are all health approaches that police are involved with. Responding to natural disasters, flooding, alcohol regulation and public order, searching for lost people, disease including HIV and other communicable diseases and epidemic control. And that's where I have been involved with over the last probably 10 or 15 years. Very much about HIV prevention and harm reduction. How do you get police engaged, involved in HIV prevention programs? I was very fortunate in 2005 to be selected to represent, I guess, the Victoria Police in an AusAid project in Southeast Asia, where I was a technical advisor. And it was my first time working with law enforcement overseas in HIV prevention. And I got to know, I guess, the challenges of working with police around particularly needle and syringe programs, methadone, condom distribution. And I found that, police are the same wherever you go. They may talk a different language, but they have the same issues. And certainly in terms of harm reduction and HIV prevention, there are a lot of challenges for police. I guess there's a conflict in how they see their role. But what I try to explain to police is that you have a role across a whole range of issues to do with health. And it's not, beyond reason to suggest that, they have a very, very important role in disease prevention, mental health issues, crisis situations in the community, particularly family violence. Family violence is an issue which is an area where I think, personally, that police have turned their back on, particularly women, over a long period of time, bashed women. And it's something which I think, many police officers would recognise as an area of neglect. So we do have a strong, I guess, presence in the health sector, and we can provide that connection, that nexus to health services and welfare services and social services. And I think this is really important for police to be aware that they do have, I guess, a multi-pronged role. It's not just about law enforcement, that there is a role for police in making these connections in terms of making or creating a better, healthier society. And I'll talk about how they can do that in a few minutes. So examples of effective police policy and practices that reduce drug harm and reduce HIV risk. And these are policies and practices that I've implemented or developed, and also ones that I've been involved with teaching police about over the last 15 or so years, 20 years. So some of the safer injecting practices policies. Police should not remove needles and syringes from people who inject drugs, use other items as evidence of drug use, which particularly use needles and syringes, particularly even clean needles and syringes. We hear about police removing them and destroying them. So that obviously leads to people sharing injecting equipment, leads to risk in terms of HIV and other bloodborne viruses. There's lots of evidence around people who inject drugs, particularly in public places, discarding needles and syringes quickly if they think they're going to be caught by the police. So policies around not seizing needles and syringes are really critical in terms of reducing risk. Police should not conduct unwarranted patrols, person checks in the vicinity of needle and syringe programs, supervise injecting facilities, consumption rooms. We have one in Australia, in Sydney. Police have a policy not to target those needle and syringe programs and consumption rooms. We have needles and syringe programs all over Australia. There's also legislation in Sydney, in New South Wales, around police operations not being conducted near the consumption room in Sydney. And that includes needle and syringe programs which are mobile outreach and dispensing machines, which also exist in Australia and other places in the world. So not targeting those places where people can get clean injecting equipment to enforce use and possession offences in terms of drugs. Supporting safe sex practices, particularly not seizing condoms from sex workers, not exploiting, harassing sex workers. I was recently, early this year, in a country where the police were saying, well, we don't get many complaints of assaults from sex workers because when we do get a complaint, the first thing we do is charge them with sex work. So you can see how counterproductive that is. It's just an appalling situation. So it can work. It does work. We've had some good results, particularly in countries where law enforcement is more around public security, particularly places such as China. I worked in southern China, Kunming, places where there's high rates of HIV. We've had police supportive in terms of World AIDS Day, giving out information to the public. Police can have a very strong presence when it comes to getting that message across. We've set up sites when I was with the AusAid program in Southeast Asia, in southern China and other places where police have been supportive. They've been parts of local drug action teams or action teams, technical working groups, and highly engaged and also very, very effective in what they do, particularly in terms of their leadership in the community. They can be very effective in terms of gathering public support for HIV prevention programs, particularly the more contentious ones, which there's still a lot of misunderstanding in communities around needle and syringe programs, for example. Overdose, not attending scenes of non-fatal overdoses, which I think is quite critical in terms of, generating amongst peers, amongst user groups and other organisations and drug-using communities, and even places like nightclubs and other places where people are using drugs, so that they know if they call for an ambulance, the police won't arrive. So there's that motivation, or there's that, I guess there's no barriers there in terms of not ringing for an ambulance. The fear of prosecution is removed. And also, and I noticed this is happening a lot in the United States, that police are actually carrying naloxone with them, the opioid overdose reversing drug, which I'd like to see in Australia and other places. There's no reason why police shouldn't be carrying naloxone. Cautioning and diversion programs. So these are more around how law enforcement can work within an environment where there are specific laws around, obviously, drug possession and drug use. And as I said from the beginning, this isn't about drug policy as such, but this is kind of working within the environment that we have. And police will often say, well, look, there's some things that I'd like to do to support, whether it's HIV prevention or other types of programs, or looking at ways in which, we can deal with drug use or drug offences in a little bit more considered way, in a way in which there's better outcomes. So cautioning and diversion programs are quite popular in terms of, acceptance by police. I was with the Victoria Police when they first brought in cautioning programs, and there was a lot of opposition to them at first, particularly around cannabis. But when we pointed out that, the surveys of police officers is that a lot of police officers actually throw cannabis away if they find it on someone, that actually does present a bit of an issue around, themselves working in an unethical way. They said, oh, okay, yeah, and it's quicker. Like it's, you spend how much time interviewing someone for cannabis possession, and you can give them a caution, which takes about half an hour, and it's out of the way, there's no more paperwork. Oh yeah, I like that idea. That's a good idea. No, that's more acceptable. There's something in it for them. Okay, so admit the offence. These are all the criteria which are common in drug diversion programs. So we're not saying to police don't do your job. We're just saying to police, look, if you do come across someone and that possession charge or that that use charge is something which you're in a position to, or you're in a position where you feel that you need to act, then look at this as an option. Give this opportunity to someone to get into a drug diversion program. And I know others have said, well, not everybody is drug dependent, not everybody wants to get into treatment. That's true. So but in most cases, all a person does is attend assessment and treatment, one case of treatment. And that can be a harm reduction episode, So that's an opportunity. And very few people come back into the program. Very few people either get detected by the police again, which is probably more the case, or go back to the next treatment episode. Okay, so this is just, I guess, the mechanics of it all. So, so just quickly going through some of this, in my notes, and there's lots of information about, drug diversion programs. They work differently in different places, but basically the mechanics are that if a police officer finds someone with a small amount of drug, they can divert them through to assessment and treatment, or in some countries, in some places, they can actually caution them for a small amount. So police custody, managing people in custody who have a drug problem or may have a drug dependency in terms of withdrawal, ensuring there's medications available, access to methadone, for example. I did some research for the UNODC a few years ago, and I came across some interesting stuff in the UK where some police forces actually give needles and syringes or provide an opportunity for an NGO or local health service to come into the police station and they actually give out clean needles and syringes when a person is released from custody, which I thought was an interesting approach and quite, I guess, a legitimate way of saying, well, look, if you go back out there and you use again, make sure that you have clean injecting equipment. Referral to local agents, needle and syringe programs, supervised injecting programs. There's lots of examples of police providing informal referrals to those types of programs. Law enforcement assisted diversion. This is a program that's happening in the United States. It's been operating for about 5 or 6 years. It's gained a lot of popularity. It's a way in which a person can go into a diversion program or be diverted into a social welfare health opportunity in terms of engagement with the service, police, either prior to someone committing an offence or maybe a minor offence, say drug use or sex work, that the law enforcement officer, thank you, the law enforcement officer may come across. So the lead has been operating for, as I said, 6 or 7 years, and the results are quite good in terms of the recidivism. So, and as we know, it's far more cost-effective to deal with a situation or deal with an incident in this way rather than have someone incarcerated in terms of costs. I think it costs about 110,000 Australian dollars per year for someone to be incarcerated, and if those funds obviously can be saved and put into other types of programs, then that's a great outcome. That's a better result. So some of the, I guess these are some of the approaches that I've, I guess, been part of or believe is necessary in terms of looking at ways in which police can adopt these approaches in terms of particularly the HIV prevention, the harm reduction approaches, and some of the different policies that I've spoken about today. So pre-service training is quite critical. And I know there's some pre-service training programs that are starting to operate in South Africa and other places, particularly the ones that are not standalone training. I've found with standalone training, what happens is that something else will come along and there'll be a crowded curriculum, and they'll look through the curriculum and they'll say, well, we've done this, training for police around harm reduction, HIV prevention. We'll take that out and we'll put this other one in. So it has to be across the curriculum. It has to be sustainable, and it should be integrated in all aspects of curriculum, not just as a standalone course or program, and it also has to be examinable. I ran training for police in Victoria for about 5 years on drug diversion programs, the policies around needle and syringe programs, and it wasn't until 12 months afterwards, 12 months down the track, that I found out that they actually weren't examining on the material that I was presenting. So it has less meaning. So I'm getting 1 minute here.
That's completely my fault.
Oh, it's all right. That's okay. I'm getting 2 notes here about how long I've got. I'm actually doing about halfway. So in-service training for existing police officials, quite important in terms of particularly engagement around local services. Managers, supervisors, first-line supervisors are quite critical in terms of ensuring that policies are adhered to. Most important rank in policing is the sergeant rank, the first-line supervisor. They kind of dictate what happens at the station in terms of compliance with policies. Strategic planning, ensuring that the police organisation as a whole has a commitment to harm reduction strategies and HIV prevention programs. Interdepartmental committees at the high level, it's important that health, justice, law enforcement, that there's that kind of cross-section of agencies all working together with the same vision, that there's a consistency in language, it's not disjointed, that we all know which direction we're going towards. I think that's quite important. Advisory groups at middle management and lower management levels, particularly from key agencies, local agencies, advisory groups, working groups, problem-solving approaches towards drug issues, which are very complex and require people who are really committed to problem-solving and to resolving issues, because they do come up quite often, particularly around needle and syringe programs, injecting facilities, methadone programs, that type of interface between health and law enforcement. I talked about engaging stakeholders. I mentioned that, clarifying goals, ensuring that you're all on the same page, operational practices, policies. I've talked about some of those. So we're just about finished. We need supportive superiors. Law enforcement police officers need to or feel confident that what they do is being supported by the people above them. Otherwise, they won't participate. They won't be involved. I mentioned consistency of language and purpose. One of the major inquiries into drugs in Victoria during the mid-1990s ensured that all participants spoke the same language. We were all on the same page. We all talked about harm minimisation, reducing drug-related harm. So that language was consistent. So there was no conflict in terms of the language which was being used. And lastly, I guess, a reward system, career opportunities for police, a recognition for good work, those that take a problem-solving approach, make it worthwhile for police to be involved, and ask yourself, well, what's in it for police? If we have a system already that rewards police in terms of numbers of arrests, etc., and we want to change that, what what do we replace that with? What sorts of rewards and recognition do we provide for police so that there's an incentive to be involved in programs such as HIV prevention, harm reduction, supporting those types of approaches? So I think that brings it to the end of my presentation. So thanks very much. And I'll hand over to the next person. Thank you.